Hello and welcome to Insight Ophthalmology. This is Dr. Amrit and I welcome you to another important lecture on anatomy of anterior chamber and the angle of the anterior chamber. So without any delay, let's get started. What is meant by the anterior chamber? The anterior chamber is a potential space which is actually located between the cornea and the iris lens diaphragm. So as you can see, this is the cornea and this is the lens. Along with the lens, we have the iris anterior to the lens, which is together along with the lens is called the iris lens diaphragm. So the structure which is bounded by posterior part of the cornea and the anterior part of the iris is called the anterior chamber. And since the cornea and the iris are meeting at an angle, this angle is called the angle of the anterior chamber. The anterior chamber is about 3 millimeters in depth. So as you can see, this is about 3 millimeters in depth and this is about 3 millimeters in depth. Now the volume of aqueous which is present in the anterior chamber is about 0.25 ml of aqueous humor. The depth of the anterior chamber is not same in everyone. The anterior chamber can be deeper, that is more than about 3 millimeters in case of myopics, pseudophakic and aphakic, and it is called the deep anterior chamber. Whereas in case of hypermetropics and angle closure glaucoma, the anterior chamber is shallower, that is less than 3 millimeters in depth. The reason anterior chamber is deeper in case of myopia is that in myopia we have bigger eyeballs. Since the eyeball is big, the anterior chamber is also deeper. In hypermetropia, as we know that the eyeball is smaller, and since the eyeball is smaller, the anterior chamber is also smaller or shallower. In pseudophakia and aphakia, the normal thick spherical crystalline lens is removed and replaced or not replaced in aphakia by an flatter intraocular lens. Since the intraocular lens is much flatter compared to our natural lens, the anterior chamber will become more deeper because this fat lens we are removing from the equation. Whereas in case of angle closure glaucoma, most of them are associated with hypermetropia, and that is why they have crowded anterior chamber and shallow anterior chamber. Now there are various parts of the angle of anterior chamber. Let us enumerate them first. As you can see over here, this is the cornea, and as I told you in my previous video on the anatomy of cornea, there is a structure posteriorly, there's a layer posteriorly in the cornea which is called the Descemet membrane. The Descemet membrane will end peripherally, and that ending of the Descemet membrane will end in a prominent line, and that line is called the schwalbes line. Just posterior to the schwalbes line is a meshwork like structure or a sieve like structure which is called the trabecular meshwork. The trabecular meshwork is again divided into two parts, the anterior trabecular meshwork and the posterior trabecular meshwork. The anterior trabecular meshwork is usually non-functional and it is also referred to as the ATM. The posterior trabecular meshwork is involved in the outflow of the aqueous humor and it is also called the PTM. Posterior to the posterior trabecular meshwork, we have the scleral spur. This is the scleral spur. And all these things, whatever I'm telling you, they extend 360 degrees. And the diagram over here is only showing you a part of the angle. Since the eyeball is the round and the cornea is round, the anterior chamber is also present 360 degrees and you have to imagine it like that. The scleral spur is present posterior to the trabecular meshwork, and then posterior to the scleral spur, we have the ciliary body band. And posterior to that, we have the root of the iris, that is the insertion of the iris. Now at this point, it might be very confusing. However, let me explain it to you one by one. To understand the anterior chamber and its angle, it is very important to understand the concept of scleral spur. In this diagram, as you can see, this is the cornea. Okay, and the junction between the cornea and the conjunctiva or the sclera is called the limbus. Okay, so this is the cornea. The cornea is ending at the sclera at a point which is called the limbus. So externally what we see is the limbus. However, internally inside the eye, internal to the limbus, there is a groove or an indentation present, and this groove is called the scleral sulcus. Over near to this indentation or posterior to the indentation, we have a spur-like or a projection present in the sclera interiorly, and that projection is called the scleral spur. So a spur is nothing but a projection. So this projection is going to be present about 360 degrees. Okay, so it is everything that I discussed will be present throughout the anterior chamber. So this is the scleral spur. This picture over here is a gonioscopic image of a normal angle, and the scleral spur is actually seen in the gonioscopy as this whitish ridge-like structure. So this white line which is present in between these two dark arrows is actually the scleral spur. So as you can see, it is present quite posteriorly. Now let us talk about the scleral sulcus and the ciliary body band. As I already told you that inside the limbus there is a groove or indentation. That groove or indentation is called the scleral sulcus, and posterior to that we have this spur which is called the scleral spur. This is the ciliary body, and these are the ciliary processes. The ciliary processes will produce the aqueous humor. Okay, and this aqueous humor will then flow behind the iris, go to the pupil. From the pupil it is going to enter the anterior chamber, and from the anterior chamber it will drain into the angle via the trabecular meshwork, so on and so forth, right? So now what you should know is that the ciliary body is attached to the scleral spur, okay, as shown over here. However, it is not attached very tightly. There is a potential space between the sclera and the ciliary body, and that potential space is called the supraciliary space. Now, as you can see, this is the iris. The iris is attached to the anterior surface of the ciliary body in such a way that a part of the ciliary body is present in between the scleral spur and the iris. And this part of the ciliary body which is present in between the scleral spur and the root of the iris is seen to us in the gonioscopy or in the angle of the anterior chamber. And this small part of the ciliary body that we see is called the ciliary band or the ciliary body band. So essentially the ciliary body is present behind the iris. However, there is a part of the ciliary body which we see in the angle because of the insertion of the iris onto the anterior surface of the ciliary body, and that part of the ciliary body that we see is called the ciliary body band. So over here, this picture, you can see the first picture. This is the scleral spur. So the scleral spur is extending 360 degrees like this, okay? And over here is the iris. So these undulating things are the iris, and in between the iris and the scleral spur, a part of this ciliary body is seen in brown color because this is a pigmented iridis, okay? So in this brown color structure, the brown part of the ciliary body that we see is called the ciliary body band. So in this gonioscopic picture, let us find where is the ciliary body band present. So as I told you in the previously that the white ridge-like thing that we see posteriorly is actually the scleral spur. Okay. Now this over here is the pupil. So definitely this is the iris. Now the brown part that you see behind the scleral spur and in front of the iris is actually the ciliary body band. So ciliary body band is actually present posterior to the scleral spur. So what happens in angle recession? Angle recession is nothing but it is the splitting of the layers of the ciliary body or the muscles of the ciliary body. The ciliary body actually consists of 3 layers of muscle. So we have the longitudinal muscle fibers, we have some radial muscle fibers, and then we have certain circular muscle fibers. So whenever there's a blunt trauma, sometimes there can be a split between the longitudinal and the circular muscle fibers, leading to expansion of the ciliary body area. So the ciliary body band will look quite thicker than its usual thickness. So this is the scleral spur, the whitish area, and behind that you can see this quite thick ciliary body band. So this thickness of ciliary body band is not normal, and this is angle recession. Similarly here you can see this quite thick ciliary body band, and this indicates angle recession. Now in angle recession, the faculty of outflow of aqueous humor is affected. So what I mean to say is the aqueous humor outflow will be decreased, and therefore there will be more buildup of pressure within the eye. So the intraocular pressure will be raised, and angle recession can actually lead to angle recession glaucoma. Coming to another condition which is called the cyclodialysis cleft. In cyclodialysis cleft, what happens is the ciliary body will get separated from the scleral spur. So what did I tell you? The ciliary body is actually inserting into the scleral spur, right? So if it gets separated from the scleral spur, there will be a cleft or an opening which is formed, and that is called the cyclodialysis cleft. Now, contrary to the angle recession, what happens in cyclodialysis cleft is that there will be more filtration and more space for the aqueous to leave the eye, and since more aqueous humor is leaving the eye, the IOP will go down, and therefore in cyclodialysis cleft, unlike the angle recession glaucoma, we will have decreased IOP and we will actually have hypotony. Now let us talk about the trabecular meshwork. So we talked about the scleral sulcus. So I explained you what is meant by the scleral sulcus. It is an indentation which is present, okay, on the inner side of the limbus. So that indentation is actually covered by this sieve-like structure, and that sieve-like structure is called the trabecular meshwork. So normally what is happening, the ciliary body processes are making the aqueous humor, and then that aqueous humor is flowing from behind the iris to the pupil. From the pupil it is coming into the anterior chamber, flowing over the iris, and then again it is going into this trabecular meshwork. So that is a normal aqueous flow. So this is a diagrammatic representation of the trabecular meshwork. So this was the scleral spur and this is the scleral sulcus. The sulcus, you can see, is covered by this net-like thing, and it is present 360 degrees, and that is called the trabecular meshwork. Now, before I go into details of the trabecular meshwork, let me tell you something about the SCLEMMS canal. So, if you know, this was a scleral spur and this is the trabecular meshwork, there is an opening, okay? So, the scleral, we can say that the sulcus is actually converted into a canal by the trabecular meshwork. As the trabecular meshwork will actually bridge the scleral sulcus, it will convert the scleral sulcus into a tube, and that tube is called the SCLEMMS canal. Okay, so SCLEMMS canal is present about 360 degrees because the scleral sulcus is present 360 degrees, your trabecular meshwork is present 360 degrees, everything, the angle itself is 360 degrees. So I want you to imagine it in that sense only, that all the structures of the angle are also present 360 degrees. So SCLEMMS canal is also a channel, a tube which is extending 360 degrees near the on the inner side of the limbus. Okay, the diameter of this canal is about 190 to 350 microns in the sclera. Okay, and it lies just posterior to the sclerocorneal junction. Now the SCLEMMS canal is oval in shape, and the important thing about this canal is that it is lined by the endothelium. So this is the trabecular meshwork which is converting it into the canal, and this canal is actually lined by endothelium, and it can communicate with the anterior chamber through the trabecular meshwork, as I told you, internally. However, externally this canal is actually perforated by about 25 to 30 aqueous collector channels. So there are other channels or routes through which the aqueous will flow into this from the SCLEMMS canal outside into the sclera and the episcleral veins, and those collector channels which are present, they are called collector channels, and then again they are going to branch and form certain plexus within the sclera. So if they are forming plexus within the substance of sclera, it is called the intrascleral plexus, and sometimes deep to the sclera also, which is called the deep scleral plexus. So this is the picture. As I told you, everything is present 360 degrees. So the SCLEMMS canal is present 360 degrees, as you can see. So internally they are collecting the aqueous from the trabecular meshwork, and externally they are opening into the collector channels, and those collector channels are again forming the intrascleral venous plexus and deep scleral plexus, and finally they are going to go and drain into the episcleral veins. Okay, so episcleral veins are the veins which are going to be present on the surface of the sclera, on the episclera. So ultimately they are going to drain into the cavernous sinus, okay, via the ophthalmic veins. So these collector channels are going to open into these episcleral veins. Now what you have to remember is that as I am calling the SCLEMMS canal a tube, it is not exactly a rigid tube. Okay, SCLEMMS canal is not a rigid tube. What happens is that actually the scleral spur, this is the scleral spur, okay, the scleral spur is actually connected with the longitudinal muscle fibers of the ciliary body. So this is the ciliary body, ciliary processes and ciliary body. As I told you, the ciliary body is connected to the scleral spur. So over the scleral spur, we have the longitudinal muscle fibers. So as the longitudinal muscle fibers contract, okay, what happens is that the SCLEMMS canal will also get pulled towards the ciliary body, and it will lead to opening up of the SCHLEMMS canal, leading to more drainage of the aqueous humor, and it will cause decrease in the IOP. That is number one. However, sometimes what happens is that, as I told you that it is not a rigid tube, when the pressure gets built up inside the eye, so in case of increased intraocular pressure, the SCLEMMS canal will actually collapse together. So there will be, from a tube, it will get collapsed together because of the inside building up of the pressure. So here what I mean to say is that it's not a rigid tube. It can vary its shape either by the pull of the longitudinal muscles of the ciliary body or by the raised ICT. So this picture over here shows that this is the scleral spur and this is the SCLEMMS canal. Okay, so you can see that this is the longitudinal muscle fibers which are actually inserting onto the scleral spur. Now let us try to understand what is meant by the Schwalbes line or the Schwalbes line. So as I told you that Schwalbes line is nothing but it is the posterior ending of the Descemet's membrane, okay, and trabecular meshwork will start from where the Schwalbes line will end. So trabecular meshwork inserts into the periphery of the cornea when the trabecular meshwork, this is the trabecular meshwork, okay, as this trabecular meshwork inserts at the scleral sulcus, it also creates a kind of ridge-like structure, a ridge-like elevation, okay, so a ridge is created, and that ridge, since it's also coincides with the ending of the Descemet membrane, and this ridge is called the Schwalbes line, which is the most anterior most part of the angle that we see when we do a gonioscopy. So this picture over here shows the Schwalbes line, okay, represented by the black arrows, so it looks also whitish in color. However, recognition of Schwalbes line might not be so easy, and it is done by using a special technique in gonioscopy which is called the corneal wedge, in which a slit of light is actually focused on the angle, and you get two slits, anterior beam and a posterior beam, and where the anterior and the posterior beams will meet, that they will form a corneal wedge, and that wedge will help you to identify the Schwalbes line. Now what is meant by posterior embryotoxon? Sometimes the Schwalbes line will be very prominent, and also there will be it will be more anteriorly displaced. So usually do not see the Schwalbes line from the naked eye or from the external examination. You only see it in the gonioscopy. However, sometimes, like in this picture, in these pictures, the Schwalbes line will be more anteriorly present. You can see it is seen almost inside the limbus. That means it is anteriorly displaced or centripetally displaced, and moreover it is more prominent. So such a prominent Schwalbes line or a centripetally displaced Schwalbes line is called a posterior embryotoxon. Now this posterior embryotoxon is clinically important because it is associated with Axenfeld-Rieger syndrome, and in such patients IOP should be definitely checked because glaucoma is an association in Axenfeld-Rieger anomaly or syndrome. Now in certain conditions the Schwalbes line might be showing this pigmentation, okay, and this is called the pigmented Schwalbes line, also called the SAMPAOLESI line. Now such a line is significant because it is seen in PXF, that is pseudoexfoliation, and also seen in pigment dispersion syndrome, okay. So SAMPAOLESI line is also very important because it is associated with these two important syndrome. Now let us talk about certain details of the trabecular meshwork. So as I told you that the trabecular meshwork is actually a sieve-like structure which is covering the scleral sulcus and converting it into the SCHLEMMS canal. However, it is also having various kinds of layers to it. So as you can see, the innermost layer is the uveal layer. Then outer to that we have the corneoscleral layer, and then the most outermost part of the trabecular meshwork, which is present just in close association with the SCLEMMS canal, is called juxtacanalicular portion of the trabecular meshwork. Now here I would like you to observe that the uveal part of the trabecular meshwork, that is the most innermost part of the trabecular meshwork, is actually having very big holes. Okay, so these meshes are very big for easy filtration of the aqueous humor. So as these holes are quite big in the uveal part, there is almost no resistance to the outflow of aqueous in the uveal part of the trabecular meshwork. After that we have the corneoscleral part, in which the holes are getting converted into these elliptical holes. And then we have the juxtacanalicular part. The juxtacanalicular part is having the thinnest kind of holes and offering the maximum resistance to the outflow of the aqueous. Now this trabecular meshwork is also composed of endothelial cell, and it is actually contractile spongy tissue. Okay, it can also contract along with the movement of the ciliary body longitudinal muscle fibers and along with the movement of this scleral spur. Okay, so what happens is that whenever the longitudinal muscle of the ciliary body will contract, what happens? The scleral spur will be pushed backwards, and the trabecular meshwork will open, and there will be more drainage of the aqueous. Now in cross section, the trabecular meshwork will look triangular. Okay, so it looks triangular in cross section, and the apex of this trabecular meshwork is present towards the cornea, and the base, as you can see, is present towards the scleral spur. The parts of trabecular meshwork, as I told you, those are the parts of the posterior trabecular meshwork. There is also anterior trabecular meshwork, which does not have much function. And the posterior trabecular meshwork is divided into uveoscleral, corneoscleral and juxtacanalicular, in which the juxtacanalicular is sometimes the most resistant part, and also referred sometimes as the cribriform layer. Okay, so the juxtacanalicular is present closest to the SCLEMMS canal and has the least size of the pores and the maximum resistance. Now there are certain age-related changes which occur in the trabecular meshwork, and this is very important for us to know this. So what happens with age is that the pigmentation of the trabecular meshwork increases. As I told you that the trabecular meshwork is lined by the endothelial cells, so the number of endothelial cells will also go down. Then the basement membrane of the trabecular meshwork will get thickened. All the debris through constant filtration throughout the life will get accumulated, and the glycosaminoglycans deposition will also increase along with age. So all these things will lead to increased resistance and decrease outflow in these patients along with increasing age. After trabecular meshwork, we have the ciliary body band, which I already discussed with you, and then we have the root of the iris or the peripheral iris. So we know that the iris is inserting onto the ciliary body, and so the insertion of the iris is called the root of the iris, and the iris is usually the thinnest at the point where it is getting inserted onto the ciliary body. Okay, next question is, what is meant by plateau iris configuration? So let me tell you. First thing what I wanted to know is the iris is thinnest at its insertion. However, in cases of however, what happens in mydriasis is that, okay, so what is mydriasis? Mydriasis is dilatation of the pupil, right? So in a normal meiotic state, when the pupil is not dilated or undilated state, the root of the iris will be the thinnest portion of the iris. However, when mydriasis happen, the iris is going to get clumped together at this point, and the iris structure or the shape will also get changed from that thin location to this clumped appearance in the angle. Now what happens in Asians is that we already have a thicker root of the iris. Okay, so instead of being like this so thin, it will be more thicker in the Asians. So what happens if the iris root is more thicker in Asians? If we put drops, so what happens in mydriasis is that the iris crowding will increase, the root of the iris will get more crowded, and there are more chances of angle closure. So because of that anatomical difference between Asians and Caucasians, Asians are at more risk to develop the angle closure glaucoma. Okay, so because of the configuration of the iris, because of the more thicker iris root, and because of the more crowding at the iris root. Next is the iridodialysis. So as I told you, there is cyclodialysis. The iris itself can get separated from the root of the iris also can get separated from the ciliary body, and in such case you will see a D-shaped pupil like this. So normal pupil is circular, and when the part of the iris gets detached, that pupil, the part of the iris will move like this, and you will get a D-shaped configuration to the pupil. Then other structures that you see in the angle is the normal blood vessels. So the question is, how do you differentiate between normal blood vessels and abnormal blood vessels, that is the neovascularization of the angle which is seen in neovascular glaucoma? The normal blood vessels usually will be radial in configuration or vertical in configuration. So what I mean to say is, if this is the angle and this is scleral spur, the normal blood vessels will be like this. Okay, they will be radially arranged or vertical. So they will be radial or they will be vertical. However, usually the normal blood vessels will never ever cross the scleral spur and go like this. Okay, so normal blood vessels will never cross the scleral spur. So if you see any blood vessels growing in tufts, irregular shape and irregular ways other than the radial and vertical branches of the anterior ciliary artery, and those vessels are crossing the scleral spur, then you can think in terms of abnormal neovascularization in such cases. So this was about the anatomy of the anterior chamber. I hope it was useful. In our next video, we will talk about examination of the anterior chamber and then about the investigative modality, that is gonioscopy of the angle of the eye. That's all for today. Thank you and have a nice day.